Hello, welcome back. I'm Brandon Winchester, and we're going to be doing our head-to-toe block scanning demonstration videos starting today with the blocks above the clavicle. If we're truly going head-to-toe, we'd be starting with interscaling and working our way down the brachial plexus to supraclavicular, infraclavicular, and axillary, respectively. In fact, what we're going to do, as I usually do with scanning demonstrations, is make our first video the supraclavicular block. The reason for that is that when we're doing an interscaling nerve block, as you'll see in the next video in this series, I typically recommend that people start with the supraclavicular scan and scan their way up the neck to identify more easily the brachial plexus at the interscaling level. So, as such, it makes sense to first learn the supraclavicular block followed by the interscaling nerve block. So we're going a little bit out of order anatomically for this supraclavicular block video. To get things started, I'll tell you a little bit about why we do supraclavicular blocks. And there's multiple schools of thought when it comes to supraclaviculars, or supraclavs as we call them. The first school of thought was the Duke thinking, which is shared by a lot of people out there, that the supraclavicular is the spinal of the arm. It's effectively the block that you use for non-shoulder surgery of the upper extremity. And that is effectively true. You can use the supraclavicular block even for shoulder surgery, some argue, although we find interscaling blocks to be the preferred choice for that. But outside of shoulder surgery, you can use supraclavicular blocks for blocks of the proximal arm all the way down to the fingertips. And there's some pros and cons we'll talk about in utilizing supraclavicular versus alternative blocks below the clavicle. But it is very reasonable, as those at Duke and those at other institutions prefer, to use supraclavicular blocks as your block of choice besides interscaling for shoulder surgery, for other surgeries of the upper extremity. As I said, you can use this block for just about any other surgery besides shoulder surgery, and it can be used essentially interchangeably with infraclavicular nerve blocks. So the natural next question is, well, when do you decide supraclavicular versus infraclavicular? Well, the more important question is the flip side. When do you want to avoid a supraclavicular nerve block? Well, usually that's in patients that you're concerned about their pulmonary function. Supraclavicular nerve blocks, although some techniques have shown lesser incidences than others, supraclavicular nerve blocks are most concerning in terms of complications, in terms of side effects, for their risk of causing phrenic nerve paralysis and therefore hemidiaphragmatic paresis of the ipsilateral, the same-sided diaphragm. And so if you block the phrenic nerve, which happens anywhere from 16 to 67%, depending on which studies you look at, if you block the phrenic nerve, it keeps the diaphragm from essentially opening and closing the lungs, from allowing the patient to breathe fully on that side, and therefore could compromise the pulmonary system, especially in a patient who already has underlying pulmonary disease. So patients to avoid supraclavicular blocks are typically COPD patients, patients who have significant pulmonary disease, either obstructive or restrictive pulmonary disease, especially those that are already oxygen dependent. Typically, if you're oxygen dependent, that implies that you have a significant amount of lung disease. And it may be difficult to predict which of those patients, anywhere from that 16 to 67% range, which of those patients are going to get a phrenic block. So if all else is equal and your coin flip decision between infraclavicular and supraclavicular in terms of your preference between the two, and a patient has comorbid lung disease, well, of course, you're going to choose to stay below the clavicle where the risk of phrenic nerve block is negligible. So supraclavicular blocks are not going to be the optimal choice for patients with comorbid lung disease. On the flip side, if all else is equal, the supraclavicular block is, by all accounts, a somewhat easier nerve block to perform for a couple of reasons. One is the patient remains in a very neutral position, as we'll show you in a minute, only having essentially to turn their head to the side in the position in which they're laying when you get to their bedside. But it's also a very superficial target. The trunks and divisions of the brachial plexus are very superficial at the supraclavicular level, and therefore that flatter needle angle of entry is able to be accomplished, and therefore, by most accounts, a somewhat easier ability to visualize that needle and visualize the local anesthesia being injected around those nerves. So when it comes to a supraclavicular nerve block in terms of probe selection, it is a wide linear transducer, a high-frequency linear transducer that we use. And as I mentioned in the introductory video, this portion of each of these specific block videos is going to be short because we use the same transducer for just about every video that we do, every block that we do. So a wide linear high-frequency transducer. This particular transducer has a 6 to 15 megahertz range of frequencies, 6 on the low end of the frequency range, 15 on the high end of the frequency range. Some people ask, do you adjust the frequency according to the depth of the target that you're looking at? For example, some textbooks or physicians will recommend that for the deeper targets that you use a lower frequency range, for the more superficial targets that you use a higher frequency range to give you the better resolution. I don't really adjust things too much. I typically leave the baseline frequency setting for any particular block that we're doing right there in the middle. Gen mode is what it's called on this machine, or just mid-range for another alternative machine. So we don't typically adjust the overall frequency settings much. In fact, my general rule of thumb for ultrasound guided blocks is depth, gain, and go. You adjust the depth based upon how deep the target is. You adjust the gain, which for all intents and purposes is the brightness of all the targets on the ultrasound screen, and you go. And you may use color flow to identify vascular landmarks, certainly vascular structures to avoid, but then of course when you start your nerve block you always want to turn color flow off before you get started. So we'll get started with the probe placement first. So to get things started, we're going to point out some of the surface anatomy here. As you can see, this patient is in the supine position, and various people recommend various degrees of head elevation. Some people recommend the head be significantly elevated. Other people recommend that the patient's laying perfectly flat. For our purposes here, I'll keep it simple and just keep it relatively flat. You do have a little bit of improved pulmonary mechanics if the patient is head up to some degree, but it really doesn't make a whole lot of difference what level of elevation the head is from my standpoint. To start with, we'll put the probe on just above the clavicle. We're parallel to the clavicle to start with, and we rotate the probe slightly off the clavicle such that there's approximately a 1 finger breadth separating the posterior part of the probe from the clavicle. Now notice the anterior part of the probe is touching the clavicle. As you're doing this nerve block and you're first trying to identify the major landmarks that you're going to be using to guide your way, you're always going to make sure that that anterior portion of the probe is touching that clavicle. The only real move that you're making here is a slide, posterior and anterior, along that clavicle, but maintaining that same rotation of the probe. And the other maneuver that you're going to be making to try to identify the target as bright as possible is once you've rotated in the proper amount, approximately 1 finger's breadth off of the posterior part of that clavicle, you're going to be adjusting the tilt. Now this is the tilt. This is a tilt up the plexus. This is a tilt of the beam of the ultrasound down the plexus. And you're utilizing that tilt with any single nerve block that you do. You're always adjusting the tilt up the nerves or down the nerves to try to find that best angle where the ultrasound beam reflects as close to perpendicular off those nerves as possible. Anytime the beam reflects perpendicularly off of a target, more of those ultrasound beams are going to reflect back to the ultrasound transducer and therefore be better visualized. So we're always, anytime we're doing a nerve block and we're trying to maximize the view of the target, we're adjusting the tilt up the nerves and down the nerves in what we call here the short axis view of the target. And when we get that optimal view, that's where we stop our tilt and go ahead and introduce the needle, which we'll talk about in a moment. Now some of the structures that we're going to be pointing out here of importance are the arterial, the subclavian artery, the first rib, bony, which is going to be visualized deep to both structures of the nerve and the artery. Neural, the brachial plexus, which is what we call the cluster of grapes at the level of the trunks and divisions of the brachial plexus. And at times branches off of the artery as well. And just to point out a few of those structures we just mentioned, the subclavian artery, which you can see as a round black pulsatile structure, is right here in the middle of the screen, just underneath of which is the first rib. And depending on the tilt angle of the ultrasound beam, you can tilt way down the plexus and not visualize it as well, or slightly adjust your tilt up the plexus where you can see that first rib as bright white as possible. And you always want to visualize that first rib from start to finish while you're doing a brachial plexus block at the supraclavicular level with ultrasound. The reason for that is that the dome of the pleura, which is this hazy white structure down here, although it's not critical to visualize pleura with each block, it is critical to visualize that first rib, because as long as you see that first rib, and as long as you see your needle tip is above that first rib, you cannot cause a pneumothorax with a supraclavicular block. It's not critical. I often get asked, well, can you please identify the pleura for me? Well, yes, you can often see like a hazy white here, like we see here, that's pleura. But like I said, visualizing the pleura is far less critical than always visualizing that first rib, because as long as you see that first rib, it can essentially be considered a do not cross line. Consider the first rib a do not cross line, whereas if you put your needle tip under that first rib, either accidentally or intentionally, I hate to see the latter, but if you do put that needle tip below that first rib, you're at risk of a pneumothorax. Anytime that needle tip crosses first rib, you can drop a lung, so to speak. You can cause a pneumothorax, which is probably the most concerning historic complication of a supraclavicular block, is the risk of pneumothorax. In fact, traditionally it's been reported as high as 1 to 2% of the time that people were doing traditional landmark techniques way back when they were reporting pneumothoraces. And so obviously that led to a great deal of concern, and people were not as willing to place supraclavicular blocks. But if you follow this general rule of thumb, where you see the first rib and you make sure your needle tip never goes below it, you cannot cause a pneumothorax with a brachial plexus block at the supraclavicular level, because the dome of the pleura at this location never extends above the first rib. So the next anatomic target to be concerned about is the neural target, what we all came here to do, to block the brachial plexus. Brachial plexus at this level we call the cluster of grapes. You can see me encircling it on the screen. Cluster of grapes entails the trunks and divisions of the brachial plexus. The deepest most component of the brachial plexus is approximately where the lower trunk exists. Somewhere in between is that middle trunk, and then the third of three trunks is the most superficial of the three, the upper trunk. But notice, as the name implies, this really is like a very amorphous cluster of grapes. You don't necessarily see the separation of the lower trunk from the middle trunk from the upper trunk. You just see an amorphous collection of circles, the cluster of grapes. And the goal, like any nerve block, is simply to encircle that cluster of grapes all around all three components of the brachial plexus here, the trunks, in order to get a successful block. The two things that you want to make sure to avoid are the pleura, and indirectly the do not cross line, the first rib, and of course the subclavian artery. The subclavian artery is an obvious target to avoid, generically speaking. You don't never want to put your needle into a vessel incidentally or accidentally or intentionally or otherwise. But at this particular location, because of the nature of the superficial tissue above the subclavian artery, it's not considered a compressible vessel. In other words, if you were to puncture it, it's not easy to press down on the skin and prevent that extravasation from happening at the puncture hole where you introduced into the artery, which is especially important for a continuous catheter technique with a larger gauge needle. So anytime you puncture a vessel, it's not a good thing. But when you use a big TUI needle, and especially when it's a non-compressible artery, or God forbid the patient is anticoagulated, that's a very bad complication. So don't cross below the first rib, and do not puncture that subclavian artery, and encircle the nerves, and that's really the name of the game. Now, generally speaking, in answering the question as to where to put your initial needle tip, you're going to place the needle tip with any ultrasound-guided block deep to the target. And in this case, we call the deep area, deep to the target of the nerves, the corner pocket. And the corner pocket is essentially the angle where the first rib joins that subclavian artery. It's like a little bit of a narrow angle there, the corner pocket. Now that's important from a supraclavicular block standpoint for a generic reason and for a specific reason. Generically speaking, this principle applies to any ultrasound-guided nerve block, and that is that you always want to put your initial injection deep to the target, because all that local anesthesia that you inject is going to push up on the nerves, pushing them more and more superficial, such that subsequent needle redirections, when you pull back your needle and you redirect your needle several times, every subsequent needle redirection is going to involve a flatter and flatter needle trajectory. And flatter needle trajectories make it easier to visualize your needle. On the flip side, if you were to make your first injection superficial to a nerve, in this case the trunks, you'd push the nerves deeper and deeper. And therefore, with each subsequent needle pass, you'd be forced to go deeper and deeper, and therefore more and more difficult to see your needle with each pass. So you always want to make your most difficult needle pass first, with this particular block or with any particular block, thus making that the generic reason why you want to place your needle tip in the corner pocket. The more specific reason is that the lower trunk exists down in that corner pocket region, and there's plenty of anecdotal evidence, at least, that if you place some or even all in some circles your local anesthesia down in that corner pocket, you're going to have a rapid onset time for a complete supraclavicular block, especially the lower trunk, which not only is important for the ulnar component of your brachial plexus, but also very important for the osteotomes of the wrist if you're doing wrist surgery. So although there is data that says it's a good idea to redirect your needle some to get a little bit more complete encircling of the brachial plexus versus just finding one specific injection point like the solo location of a single injection at the corner pocket, it does make sense at least to make your first injection at that corner pocket location. So now we're going to go ahead and show you where the needle insertion will take place with a supraclavicular brachial plexus block with ultrasound. You can see in the big picture shot here that the needle, the probe is positioned exactly as we described earlier, and the needle, which is my pen here, is going to insert a little farther from the probe than you're used to seeing. Now granted, on our ultrasound screen, the target's only about 1.5 centimeters to 2 centimeters deep, which is useful information. The more shallow the target is, the less far away from the probe posteriorly that you need to insert your needle. This is going to be an in-plane technique, and since this is a superficial structure, we won't insert our needle much more for her than a few centimeters posterior. But even so, generally speaking, no matter what nerve block you're doing, we typically recommend that people insert their needle at least 2 to 3 centimeters posterior to the probe, which I can show you here a little bit better with this close-up shot. Now you'll often see pictures in ultrasound images from websites and textbooks, etc., where needles are inserted, no matter what block you're looking at, needles are inserted right next to the ultrasound probe, which is, I think, an incorrect way of doing nerve blocks with ultrasound on 2 levels. The first level is that inserting closer to the probe, no matter what nerve block you're talking about, no matter what depth, is going to be a steeper angle of insertion than if you inserted several centimeters farther back from the probe. And therefore, the steeper the needle angle, the more the ultrasound waves are going to refract when they bounce against the needle, as opposed to reflect, which is what you want them to do, and because reflection is what makes you able to visualize the needle at all. Anytime that you're visualizing something on ultrasound is because an ultrasound wave is reflecting back to the ultrasound probe. So getting a greater degree of success at reflection versus refraction involves trying to get as close to a perpendicular angle of the ultrasound beams against the needle. And the way in which that's accomplished is twofold. One is to insert a few centimeters farther from the probe, and the other is to rock the ultrasound probe itself back to the needle. And the way in which rocking should be considered is essentially this is a perpendicular angle of beams hitting needle. If this is a 45-degree angle of the needle now, a lot of those beams are going to hit the needle and refract off of the needle. In order to better achieve a close to 90-degree angle of the needle, you want to rock your probe beam back towards the needle. So this is a rocking motion, and again, an often overlooked maneuver. It's not even mentioned in the original description of the part maneuvers. So we joke that this is the part maneuvers with 2 R's, because you always want to be. It's always important to focus on that additional R, that rocking maneuver. The heel-toe maneuver is another way of describing that, such that the ultrasound beam is angled, shall we say, back towards that needle. So now that we've demonstrated the 2 methods to see your needle better, one is to insert the needle a little farther from the probe, and 2 is to rock the beam a little bit back towards the probe. We'll demonstrate on the screen where you want that initial needle pass to go. The needle will be introduced from left to right, which is posterior to anterior in anatomic terms. Notice that the target I've moved to the opposite side of the screen, the right side of the screen, the anterior side of the screen. The reason for that is on the flip side, you don't want to have the target right where your needle's about to be introduced, such that when your needle first enters the screen, you're already at the target. You lose major style points if you're doing a dual guidance technique and you get a nerve twitch before you've ever had an opportunity to visualize your needle. So you want to make sure, for safety's sake, to move the target more to the opposite side of the screen so you can initially visualize your needle as it enters the screen from left to right, posterior to anterior, where there's not really any dangerous structures back here to be concerned about. Visualize your needle, improve your view of your needle by rotating the probe such that the needle is visualized along its entire length. We call this the in-plane needling technique, where you can see the needle along its length in plane. Visualize that needle in, and then in real time, guide that needle into that corner pocket where you're visualizing the needle along its entire course. And like I said earlier, as long as you visualize that needle tip at all times, and as long as you see that it's above that first rib, you cannot cause a pneumothorax, and you can better give yourself a better degree of confidence that your needle tip is where you want it to be. And in this particular instance, for the first needle pass, just under that brachial plexus. Now this is where the hydrodissection technique, I believe, comes in handy. Now you can use a technique of dual guidance. You can stimulate, go to one particular location with your needle tip, try to get a twitch. In this particular case, the more distal twitch, the better. And in a classic sense, a twitch of the extension of the elbow or wrist, or intrinsic hand muscle twitch, anywhere from 0.3 to 0.5 milliamps would be a helpful confirmation that you're in the correct place. But we typically advocate, not necessarily in lieu of a multiple injection technique, but not necessarily in lieu of a dual guidance technique, but certainly more important than the nerve stimulation component. We recommend a multiple injection technique, including what we consider to be one of the most important steps mentioned earlier, which is hydrodissection. And hydrodissection is essentially initiating an injection and advancing your needle as you're injecting. And what it allows you to do is not only at times visualize your needle tip a little bit better. I think hydrodissecting, if you're unclear where your needle tip is, can sometimes help you visualize it better. But also helps spread the tissues apart. It helps move the tissues out of the way as you're advancing your needle, and gives you the better ability to glide in, so to speak, to the place that you're trying to target rather than jab in by inserting the needle straight in without injecting. So typically we'll utilize a hydrodissection technique with this particular nerve block and with many other techniques by starting our injection in the deep part of the plexus but lateral. And as we advance our needle, we'll start our injection here, advance as we inject, advance as we inject, advance as we inject until we get our needle tip to about the corner pocket. And that's going to accommodate about 10 cc's of our 30 cc total injection. At that point, we'll redirect our needle by pulling back, and I'll typically redirect over the top of the brachial plexus about another 10 cc's. Now remember, the more anterior you go, we don't see the phrenic nerve, we don't directly visualize it, but just know that the more anterior you go, the more, in this case, towards the right, the more to the artery and past the artery that you go with your local anesthesia injection, the higher likelihood that you're going to get a phrenic block. So the phrenic block lies over here on or adjacent to the anterior scaling muscle. So the more posterior and deep you can keep your local anesthetic, the more, and especially the lower the total volume that you use, the more you're capable of avoiding or at least minimizing a clinically significant phrenic nerve block. So typically 10 cc's below the plexus, 10 cc's over the plexus, not going well past here, about the 12 o'clock position of the upper trunk. And then if you're able to, inject local anesthesia right adjacent to the plexus and gently advance as you're injecting your local anesthetic. And if the nerve components, the trunks, the upper, middle, and lower trunks start to separate from one another, continue to advance your needle. If you feel any kind of resistance, just continue your injection and leave the remaining 10 cc's lateral to or posterior to the brachial plexus. Now typically, with anatomy like this, the most common, although it's not clearly described in the literature where the ideal place to leave your continuous catheter is with a supraclavicular block, if you are doing a supraclavicular technique, more commonly than not, it's recommended that you leave your catheter just under the entire brachial plexus with the tip just adjacent to the subclavian artery at the anterior-most location that you can safely place your needle tip. And the benefit of that, like with any other nerve block, is that if you leave your catheter tip just under and past the target, in this case the lower trunk and the overall brachial plexus, if you leave that needle tip, or excuse me, that catheter tip just past the target, all the local anesthesia that comes out of that catheter tip is going to follow the path of least resistance. It's going to leak back along the catheter, all along the entire underbelly of that brachial plexus, and overall enhance your surface to volume ratio of local anesthesia. So you never want to leave your catheter midway or worse yet, all the way to the lateral side of the plexus, because all the local anesthesia that accumulates is going to leak away from the target nerves as opposed to under and past them. So no matter which block that you're doing, generally speaking, you want to leave your catheter under and past that target, with a few exceptions we'll talk about in each of the individual videos where they're applicable. And to round things out for the supraclavicular block, we just mentioned the catheter placement, ideally in that corner pocket location where the junction of the first rib and the subclavian artery come together, just deep to the brachial plexus. Typically we'll place a total primary block, the initial block done through the needle, of 30 cc's. And I don't make recommendations specifically about what you should do, but I can tell you what we do in our practice, which is in a total injection of 30 cc's with multiple aliquots of 5 to 10 cc's each, total of 30 cc's of 0.5% bupivacaine. We don't use epinephrine in our block solution, but a lot of people either have a mixed or pre-mixed epinephrine solution ranging between 1 to 200,000 concentration or 1 to 400,000 concentration. And depending on which local anesthetic you use, there's multiple benefits of using epinephrine. The overall incidence of vasoconstriction is higher, and therefore local anesthetic is felt to stay in the location of the injection longer and potentially make those nerve blocks last longer. And also, if you were to inadvertently inject intravascular, the epinephrine is potentially going to give you an early indication of that by virtue of tachycardia. We've taken the epinephrine out of our local anesthetic solutions. We think risk-benefit-wise, the theoretical risk of increased incidence of nerve injury because of that vasoconstriction outweighs the potential benefit that the epinephrine gives us of decreased absorption in an early positive test dose if it's intravascular. And the reason we feel that risk-benefit exists is because of our multiple injection technique. Typically, I would recommend that people consider a lower threshold for using epinephrine if you're putting all of your local anesthetic bolus in one single location. Because if you're intravascular, that's going to be a very large bolus. In our case, we're only giving 5 to 10 cc's of local anesthetic in each individual location, and only a total of 30 cc's combined for the whole nerve block. So risk-benefit-wise, although there's risks and benefits of both, we feel in our practice that taking the epinephrine out made sense to minimize the risk of nerve injury for the patients that we're doing nerve blocks for. Albeit rare to begin with, nerve injury, when it does happen, is potentially a major complication. So we felt that avoiding the epinephrine in our practice was preferable. When your patient is then discharged either to the floor as an inpatient or to home as we do for all of our patients because we're an ambulatory surgery center, you'll connect that continuous catheter to a continuous pump, either disposable or non-disposable, electronic or elastomeric. And for a supraclavicular brachial plexus block, I'll typically start the rate of my local anesthetic pump at 8 cc's per hour. And you'll see a lot of variability from practitioner to practitioner when it comes to this. In my estimation, the higher rate compared to some of our other blocks where we start the rate at 4 cc's per hour, the higher rate is justified because of the fact, as you saw in the ultrasound images, the nerves of the supraclavicular brachial plexus are more spread out. And therefore, using that higher rate per hour of local anesthetic solution, which in our practice is 1/8% bupivacaine. Some people use 0.2% ropivacaine. But either way, that higher rate allows, in my opinion, a better ability for that local anesthetic to spread to a larger surface area of nerves because of how spread out the upper, middle, and lower trunk are for your continuous catheters. The alternative school of thought, which is not the wrong school of thought necessarily, is to start at a lower rate, 4 cc's per hour, for example, and give the patient and the ability, or the nurse if it's an inpatient, the ability to turn that pump up and down. And that's what many practitioners do. That's what my partner does for these particular blocks. Starts at 4 and gives the ability to crank the rate up 6, 8, or even up to 10 cc's per hour. So it's a matter of preference. My particular preference for supraclavicular blocks is to start the rate at 8 cc's per hour. So I hope that was helpful. We gave you a little bit of a review of the basics of a supraclavicular block from the standpoint of the setup and the standpoint of the anatomy and the ultrasound scanning. If you have any further questions, don't hesitate to reach out to me, and stay tuned for more block videos, scanning from head to toe.